Chronic kidney disease is a burden which is growing in India today, even in Karnataka, Bangalore, and worldwide. Diabetes and hypertension are two leading causes of chronic kidney disease. Hi, I'm Dr. Bhavna Sosle. I'm a diabetologist and I work at Dicon Hospital, Bangalore. Several patients get referred to us quite late in the process of chronic kidney disease. And this is unfortunate because with good control of diabetes and hypertension, kidney disease can be prevented. And if someone has early kidney disease, progression can be stopped and delayed so they don't end up requiring dialysis and it does not progress any further. We can also prevent a lot of deaths from CKD just by good glycemic control, so good diabetes control and good control of blood pressure. So I ask all of you, people, doctors, patients with kidney disease or diabetes, get your health tests done, get your creatinine checked, get something called an EGFR checked. So you could ask your doctor about it, and this will tell you how well your kidney is functioning. There are several drugs that we use today, medications for blood pressure control and diabetes control, which protect our kidney. And some of these medications protect our kidney even if you don't have diabetes. So ask your doctor about these molecules and make sure you're taking the medication that can save your kidney. Not just control diabetes, but saving your kidney is equally important. And we can all do this today and make sure your family, your friends, your kids, whoever has diabetes gets their kidney function checked and they are on medications to protect their kidney. Uric acid is high. It does not mean they have kidney disease. A lot of people have a condition called as hyperuricemia, which is high uric acid levels. This can be linked to the food they eat and dietary changes can reduce that. In some other people, they also need medication to control the uric acid levels in addition to modifying their diet. But people with high uric acid can go on to develop kidney disease if this is not controlled. So they do need to check with their physician or nephrologist and get the kidney function tested. But the other way around also happens, that when the kidney is affected, uric acid levels tend to go up. So you will often find nephrologists asking for uric acid levels in the panel of kidney function tests. But if someone has normal kidney and still has high uric acid, they still would need treatment for that, so to protect the kidney.
So when a patient comes to us and you diagnose patient with hypertension for the first time, obviously we need to do some tests to find out whether it is primary hypertension or secondary hypertension, and also we look into investigations to see if the complication of hypertension has already occurred. So what are the routine set of investigations that you order for a patient who is diagnosed with hypertension for the first time in your OPD?
So first off, when the patient has a stage 2 hypertension, very high blood pressures, then we label them and possibly even start treatment early if blood pressures are very high. Otherwise, stage 1 hypertension, pre-hypertension, give a time period of about 2 to 6 months to monitor, record the blood pressure, come back with the really hypertensive. In that interim, what are the tests which are done? A urine analysis. I think it's a very, very underused tool. Many of us order urine tests, but we really don't look at it carefully. Proteinuria and hematuria are easily missed, also neglected. For instance, in young hypertensives, we all know that Burgess disease or IgA nephropathy is such a common cause of later kidney disease evolving, but that microscopic hematuria is generally ignored and not followed up. So therefore, we miss a lot of potential kidney disease patients, since this is a Kidney Warriors Forum, I'm specifically mentioning that. But urine analysis, serum electrolytes, Dr. Ranjan was mentioning in the morning that Conn's syndrome is primary aldosteronism is missed, because as soon as a patient is seen, many of us start them on ACE inhibitors or ARBs, and we miss the diagnosis of abnormalities. So serum electrolytes, serum creatinine, and then HbA1c, and then lipid profile. In addition, two important things which are not very emphasized are ankle brachial index, the blood pressure difference between the arm and the leg, because peripheral artery disease is missed frequently because of this. Many of our diabetic hypertensives suffer from peripheral artery disease. And weight, we do not measure weight many times, and it's a very important parameter. One emphasis on serum creatinine, I think, is not really justified. Today morning I was just looking up my profile. My serum creatinine is 1.1. I am 72 kilos. I am 170 centimeters, and I realized my EGFR, formula, is 80. It's not normal. For a man, EGFR should be more than 100. So, but we don't use this simple parameter. It has its problems. I do understand EGFR measurements have their own problems. But in a majority of cases, we just look at a creatinine of 1.2, 1.3 in our OPDs and say, Parvagila. And that, I think, we end up missing a lot of things. So, in addition to urine analysis, serum creatinine, a simple online formula to measure the EGFR, lipid profile, screening for diabetes should be done. And in very severe hypertension, we don't do this, all of us don't do this regularly. In PGI, when we were students, ophthalmoscope was mandatory and we were looking at everybody's funduses. We don't do that anymore in our busy practices, but I think in severe hypertension at least, we should send the patients for fundoscopic examination.
To add to this, we have the National Kidney Foundation app. It is available online. You can download it on your smartphone. All you have to do is just to enter your creatinine, your age, and your gender, and that will calculate the EGFR for you. So that is what we use for bedside EGFR calculation, estimated EGFR calculation for all our patients.
Most cardiologists end up seeing 30 to 40% of our OPD is actually hypertension, and we probably spend more time on hypertension than counseling patients for angiogram for who need it, because they have a lot more questions. It's a lifestyle disease. That is what we should understand, and there is huge role for how we talk, what we talk. One very important thing what we do is, at age of 50, 55, 90% become hypertensive. That is first thing we need to tell people, that you cannot probably fight it out. It's very likely that at some point in your life, all of us will become hypertensive. So that fear and anxiety is gone. I even tell them, better to be with the majority than minority, when you reach that. So hypertension is something. So you can escape diabetes because there is a lot of genetic tendencies, but hypertension escape is probably not possible, and it's something which we need to accept. So when you say that, it's not the drugs which are problem, it's the disease which is problem. Which is also important for us to tell to them that why are we treating hypertension? Are we treating a number or are we treating a complication? It's important to tell them that we are treating mainly to prevent a stroke, because 80 to 90% of stroke, prevent kidney disease, prevent heart failure rather than heart attack. The disease list is long, and it's very important for us to make them understand, because every patient jumps up and asks about side effect. Any drug you want to start, you start side effect. So typically what happens is, especially with those borderline stage 1, 150, 160 BPs, I don't start in the first visit at all. I have a printed sheet which is 2-page, 1 page explaining the page. I give it to almost all my patients. 1 page explaining what diet, about DASH diet, the exercise, the weight loss, these kind of things. The second page actually clearly mentions how to measure BP at home, where I strongly recommend you lie down for 10 minutes, then check. That means 1 BP measure, because there is 1 minute gap. So 1 BP measurement is a 15 minutes job, and it's important. I even tell it's better if you don't see, someone else checks for you. Doesn't even tell you the number, average it. We tend to give a lot of work. When you do this for a month, and when patient actually thinks and they know that you're not trying to put a drug, you're trying to talk to them, you're trying to get the disease under control and make them understand it. I feel it works well, because I see most of these 4 to 6 weeks later with the BP chart. By this time it has sunk in to them that they could be having hypertension, and it is not the drugs which are dangerous. Meanwhile, as Dr. Venkatesh said, those blood tests are ready. You're not again rushing them to do all the tests just because they come. Most of us tell that when you come back next time, check these blood report and come. So with that, when they come, they have done their lifestyle, they have tried to lose 4 to 5 kg, whether it's possible or not. target is only 1 kg per week. It's not that difficult for anybody. So 4 to 5 kg when you come back, it works well. Some of them take it extremely seriously and they do get their blood pressure down, and that's good. And you don't need to worry, especially if the ECG doesn't show LVH. If there are no other major parameter, it is okay by the time the reports are ready. So it's important we spend. Next time when they come, they do ask some of those questions. Then the first thing I ask, did you get this sheet? which I have. I tend to give one more sheet because we have written. Because this has been a major problem. So I have 4 or 5 sheets in just behind. One is diet for heart patient. One is on HCM, because again I see 3-4 HCM, hypertrophic cardiomyopathy a day. It's important they understand and they come back. Most people are quite literate, or there's somebody who can read English in their family and they work. The other important thing, once we do probably, I don't know, the important thing, the most common secondary hypertension now is actually obstructive sleep apnea. 60% is obstructive sleep apnea. It's not, whatever we said, it's not pheochromocytoma, however fancy it looks. The chance of us finding a pheochromocytoma in our lifetime is mostly 4 or 5 patients. But every other patient of a resistant hypertension is actually obstructive sleep apnea. So that history we should always ask and take. Because unless you manage that, and these are the ones who come with very high BP, and it's very, very common, and for some reason, say I've practiced in Manipal, Udupi, and I've practiced here, the phenotype is different. For some reason, Bangalore is a hub for obstructive sleep apnea, but the acceptance is higher here. When you tell people that you could be having obstructive sleep apnea, they accept, and some of them actually are already on CPAP mission. So I think it's very, very important. Rather than looking at fancy things, it's important. 2 important diseases when the BP is not controlled is either renal, some sort of a kidney disease where creatinine is slightly above normal, maybe 1.5, maybe 1.6, but it's definitely not normal. And obstructive sleep apnea. You tackle this, 90% of your patients are actually tackled.
Luckily, I went for insurance and I was not underqualified because 18 years was a primary. I had to go undergo medical investigation. And that time when I saw, it was doctor saw my BP, it was 200 by 90, and he was shocked. And then that's the investigation started. So eventually, doctor talked about why your early aging, and we started a lot of investigations, and then slowly and gradually the creatinine was on a borderline, as doctor said. But then I was on medication for almost 10 years or so the creatinine was unstable and all that. But eventually, I would say that uncontrolled hypertension that started decaying my kidneys. I think so, I'm not sure what, because then the kidney were shrunken and we were not able to do biopsy and identify what exactly went wrong. But but doctor, as he said, a couple of things helped me prolong. One is the salt intake in my diet, exercise, that would also help me a bit, and third thing, follow and medicines on time. That 3 things which would help a doctor constantly help me.
Giving an example of a clothes line that it's hanging there, and you pull it down with your hand, and the moment you leave it, it goes back again. So it's not that your clothes line got habituated to your hand, or it would be easier for you to say that I don't want to eat food, because if I don't eat food, then I start feeling hungry. This is a disease likely to stay with you. There are chances that if you correct some reversible causes like sleep apnea, alcohol, which has become very common now, you may be able to get rid of hypertension, but that needs a lot of dedication. 5% of patients with primary hypertension may be eventually able to get off, but you must convince yourself before you start treatment that you are going to be there with these drugs for life, and they are safe. These drugs are made for patients to take it for decades. So if you have this myth you built into your mind that once you start taking medicines, you get habituated, you're harming yourself. As Dr. Ranjan said, we are not treating a number, we are trying to prevent complications. I think this counseling, this part of the counseling where why do you have to take medicines, and that you're not getting used to the medication, but you are trying to protect yourself from complications. I think this part of the counseling should be the most extensive when we are talking to patients.